All right, thank you for your kind cooperation and attention. Assalamualaikum and hello everyone. Welcome to our webinar. My name is Daliana from the Department of Social and Preventive Medicine, Faculty of Medicine. You are joining us today for a webinar entitled Epidemiology and Population Aging in the 21st Century by Professor Dr. Robert Cumming. Before that, I would like to introduce you to the moderator of this webinar, Professor Dr. Noran Hari. Prof. Noran is a professor in epidemiology from the Department of Social and Preventive Medicine, Faculty of Medicine, UM. She obtained her MBBS from the University of Malaya in 1996. Then she continued to study public health and obtained her PhD in 2011 from the University of Sydney, Australia. Her areas of expertise are epidemiology and preventive medicine in geriatrics and gerontology, as well as aging. So without further ado, I would like to invite Professor Noran to moderate this webinar session and introduce the speaker. So over to you, Prof. Noran.
Thank you, Nick. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all, wherever you are. My name is Noran, and together with Nick, we'll be moderating this webinar today. Firstly, I would like to welcome everyone to this webinar, a webinar on epidemiology and population aging in the 21st century. This webinar is hosted and organized by the Department of Social and Preventive Medicine, Faculty of Medicine, University of Malaya. And this webinar is currently recorded live on Facebook as well as YouTube. We are very privileged and honored to have a prominent speaker with us today, Professor Robert Cumming from the University of Sydney, Australia. He is also currently our external assessor for our postgraduate programs, and he has been doing a tremendous job this past 1 week. To introduce our speaker, it's my great pleasure to introduce our speaker today, Bob, or Professor Robert Cumming. He is a professor of epidemiology in the School of Public Health. He's an epidemiologist and a physician with many years of senior leadership experience in academia, research, policy, and practice roles. He has a distinguished career in research. He has been doing research for over 30 years, 20 years on the health problems of older people in Australia. And in the last 10 years, he has expanded his research to look at non-communicable diseases and aging in developing countries in Asia, including Malaysia. He's together with us in the MALO study, the Malaysian Elder Longitudinal Research, and Africa as well. He has over more than 400 peer-reviewed publications, and these publications have been cited tremendously, an average of almost 50 citations per paper. And 19 of his papers have been cited more than 200 times, and in 2016, he was awarded the Clarivet highly cited researcher, or formerly known as Thomson Reuters. What Bob has to say to us this morning is really valuable information. So let us welcome Professor Robert Cumming. Over to you, Bob.
Thank you, everyone. Noran, you made me feel very old then.
Apologies for that.
Which fits well with the presentation today. So I'm going to be talking about epidemiology and population aging in the 21st century. And what you can see on this first slide is a picture of Malaysia's current, I guess, population pyramid, which isn't quite a pyramid anymore, and we'll get back to that later. So just to introduce myself, beyond what Noran said, I've made several visits to the University of Malaya in the last 12 years. I first came in 2008, and you might recognise some of the people in the photo there. I came back in 2013 when I was mainly involved in the MELOR study, helping design and set up the Malaysian longitudinal study of aging. And Noran is there again, as well as mostly a group of geriatricians and people involved in working with older people. And then I was back the next year as one of the keynote speakers at the APACH conference held in Kuala Lumpur, where I gave a talk similar to the one today. So I apologise, but I doubt if you'll remember 6 years ago anyway. And I've obviously updated it. I was also in Malaysia last year for my wife's 60th birthday party, which we held at Pangkor Laut, but I haven't got any pictures of that. We love Malaysia. So the motivation for this talk is that this is the world now, or 10 years ago now. I apologise that it's a little while ago. But in the last few years, that there were only three countries in the world that had more than 20% of their population over 65. So Japan, Italy, and Germany. If we look forward to 2050, so just bear this in mind, only those three countries are red with a significant proportion of their population over 65. 2050, the world has changed. Now, all North America, a lot of Asia, all of Europe, some of South America, and Australia and New Zealand will all have populations where more than 20%, 1 in 5 people are old, are over 65. You actually have a look in your part of the world, you can see Thailand and Vietnam will have over 20% of their population over 65. Malaysia will be close, but it's not quite as old as those two countries. So in this presentation, there are two parts, although the first part is much shorter than the second part. I'm going to talk about ageing of individual people, like each of us, and then most of my talk will be about population ageing as populations get older and the implications of that for the disease burden in various countries. So ageing of individuals. So this is Jeanne Calment, a French woman who died at the age of 122. And this is her on her 121st birthday. So she is the oldest person that has ever lived. Now, there are claims that people have lived to 150 and so on, but she is the person with the best evidence that she did in fact survive to 122. I think it's always important when we see older people to remember that they were once young. I think we often forget that, particularly young people. They can't imagine that they're ever going to be old, but we will all be old, particularly these days. Most of us will survive until we're old. Not 122, but we will be old. And Jeanne Calment also was young once. So there's quite a lot of debate about can we expect that our life expectancy will keep getting longer? I mean, we all know that life expectancy is going up. And there are those who believe that we might have reached some limit that, you know, an average life expectancy of 80 or so, it's never going to be 90 or 100 life expectancy at birth. There are others, though, that, and particularly these demographers from Europe, who use data to suggest that life expectancy will keep going up and up and up. And what they've done here is since 1840, when the earliest really available data for life expectancy at birth was available, they've looked at the country that had the longest life expectancy for women in that year. So if we look right at the bottom, this was Norway. In 1841, life expectancy for women was 46, and that was the longest female life expectancy in the world. And then for each year since then, or for years when they've been able to find data along the line, you go up, and this triangle is New Zealand. So white people in New Zealand for a long time had the highest life expectancy in the world. And what you can see, this line, it's a straight line. It just goes up and up and up. There's no evidence that there's some limit has been reached. So if we go right up here, these little circles are all Japan. And you can see that by 2010 or so, the life expectancy for a woman in Japan at birth was 85. And in fact, on this straight line, life expectancy increases about 3 months every year in most countries in the world. It won't be the same everywhere. And COVID might do something to that this year in those countries with high disease burden. But life expectancy, that's the age at which 50% of people will have died since birth, is going up and is now, you know, over 80 for women in many countries of the world. So there are going to be lots more old people. At an individual level, there's a debate about what is the longest that it's possible for a human being to live. Now, we saw Jeanne Calment, 122. So this is another group published in Nature, and you'll notice that previous thing was published in Science. So these are, you know, top-cited, top-ranked journals and articles. So this group, Dong et al., what they looked at was they tried to get evidence for the person that had died in a particular year. Let's look at this, 1968. The oldest person that died in 1968 was 111. And each year they've looked at the data to find the age at death of the oldest person, so the maximum reported age at death in that year. And I think they've taken the data a little far, and they've suggested that, in fact, that went up from about 1968 to 2000, and that they've put a line through about 7 points and said it's now going down a little bit. I wouldn't worry too much about the lines. I think what's interesting is that most of those maximum reported ages of death have been about 114, 115. Now, there are 3 outliers, and Jean Calment is quite a significant outlier, 122. And it is surprising. Now, she died in the late 1990s, more than 20 years ago. It is a little surprising that there hasn't been anyone that's lived anywhere near as long as that since then. And there has been some doubt raised as to whether that 122 is accurate or not. But anyway, when I look at this, what I say is that maybe human beings can only live to 115. It's still a very long time, but it seems to me unlikely that there are going to be people living to 150 or 200. So 115 is the longest any of you are going to live. Okay, so take that message home. What is true, though, is that as groups of people get older, the range in their health status increases. So if we look at people in their early 50s and using the EQ5D, a good health-related quality of life measure, the range between the 90th centile, which is perfect health, at all ages, interestingly enough, so 10% of people over 85 rate their health as being perfect. But the range is just the range from 10 to 90% is from 0.71 to 1. As we go along and we look at the oldest age group of 85 plus, there's enormous variation in how people rate their quality of life. There's still 10% who say it's perfect, but there's 10% who rate it, or the 10th percentile is at 0.4. And we all know that. We know that there are 80-year-olds that run marathons, and there are 80-year-olds that live in nursing homes. And the older we get, the greater the heterogeneity of our health and physical and mental capabilities. So that begs the question, when does old age begin? So from a health point of view, that's an impossible question to answer, really, because, as I say, some 90-year-olds are very healthy, some are very unhealthy. And this is just a quote from the authors of the paper, the graph I just showed you. Chronological age is a poor marker of the health impact of ageing for a surprisingly large number of older people today, given that different people experience vastly different health outcomes at the same age. I sometimes think of this when it's been proposed that maybe everyone at the age of 85 or 80 or even younger, everyone should lose their license. And the analogy is that at age 17, everyone gets their license, and there should be an age limit, an upper age limit when everyone would lose their license. But some 85-year-olds drive better than me, and some 85-year-olds probably shouldn't be driving. You can't just use you should try and avoid using a strict age cutoff for making decisions about what people can and can't do. And I'll come back to that with COVID right at the end of my talk. However, for a lot of decision making and for a lot of reporting, you probably do need a definition of old age. And these are the two most commonly used. OECD, and this is a direct quote, the elderly population is defined as people aged 65 and over. And 65 is probably the most commonly used age in developed countries. The UN has a younger age, lower age limit, and it says older persons are those aged 60 years and over. And I think that's a more commonly used cut point in developing countries. But, certainly in Australia, most 65-year-olds are still in pretty good health, and many are still working. But it's a useful administrative cut point. And also in the slides that I'm going to show you in the rest of the talk, some of them define old age as 65 and some of them as 60. So I've labelled the slides, but just beware of that. And whenever you hear people give data about older people, just check whether they're using 60 or 65. Okay, now, as I've hinted, one of the reasons we need an age of old age is to decide when retirement age is. And it's interesting that the first old age pension in the world was introduced in 1889, so that's 130 years ago in Germany, by Otto Bismarck. And he said, those who are disabled from work by age and invalidity have a well-grounded claim to care from the state. Now, in 1889 in Germany, there weren't very many old people, and Germany could easily afford to provide a pension for the small number of people that were old. And in fact, he initially defined the retirement age as 70. And certainly there weren't a lot of people over 70 in Germany in 1889. That was subsequently changed to 65. Interestingly, at the time Bismarck made this statement, he was actually 74 and still working very hard. Okay, that's all I'm going to say about individuals, but obviously populations are made up of individuals. So what is population ageing? It's a change in the structure of a population such that there's an increasing proportion of older people. And often it'll be illustrated by the proportion of people over 60 or over 65 in the population. And that's what I'm going to, some of the slides I show you in a moment will use either 60 or 65. But at a global level, the world's population is getting older. I probably should have called this talk Epidemiology and Population Ageing in the first half of the 21st century, because I'm not going to go beyond 2050. But this slide shows the proportion of the world's population aged 65 and over in the orange line, and the proportion of the world's population under 5 in the green line. And you can see back in 1950, only 5% of the world's population was over 65, and nearly 15% was under 5. Around about now, they've flipped over. There are now in the world more people over 65 than under 5. There are more old people than there are young children, and that is going to change over the next 20 or 30 years, such that by 2050, it'll be the opposite of what it was in 1950. There'll be 15% of the world's population will be over 65, and 5 or 6% will be under 5 years of age. So the world, without doubt, is getting older, and whatever field of endeavour you work in, you're going to have to adjust what you do to take into account there aren't going to be as many children, there are going to be a lot more old people. And that includes us public health workers. So I'll just show a few population pyramids. I'll just use one for India here. So in 2000, India had the classic population pyramid, what we all learnt about probably at high school, with a lot of young people and decreasing numbers of people in each 5-year cohort as populations get older. I've just marked with asterisks boys in India age 0 to 4 in 2000, so we can see what happens to them over the subsequent 50 years. Also notice that the x-axis goes up to 65 million, and that doesn't change in these next 3 slides I'm going to show you, but subsequently you'll need to watch the x-axis. So here we have a pyramid in 2000 of India. 2025, I suppose you could call it a pyramid, but it's not a perfect triangle anymore. And what you can see is that those little boys age 0 to 4, most of them have survived to be 25 and 29. There's not, the infant and child mortality isn't as high as it used to be. So the children are surviving to be older. And I don't think that's a pyramid anymore in 2050 in India. And probably 90% of the little boys back in 2000 who are aged 0 to 4 have survived to be 50 to 54. So we can see that the declining mortality rates in infancy, but at all ages, means that more and more people reach old age. The other thing that's happened is, in the first slide I showed you, there were about 65 million little boys aged 0 to 4. I'm just concentrating, there's no reason I'm concentrating on the boys rather than the girls. I apologise perhaps for having done so, but you can see now 0 to 4, there are less than 60 million. So the fertility rate has gone down. So there are fewer young people, and people are surviving to be old, and those are the two drivers of population ageing. If we look at different regions of the world, and we look at the percentage of people aged 60 and over, again from 1950 to 2050, the top line is Western Europe, which is already old. So I'll focus on 2005, but if you want to run your eye up to 2020, that's fine. In 2005, 23% of people living in Western Europe were 60 and over, so 1 in 4. And by 2050, that's going to be 1 in 3 will be over 60. The pale blue line is North America. There is no line for Australia and New Zealand, but if there were one, it would be almost exactly on top of that pale blue North America line, where at the moment, about 20% of the population is over 60, and by 2050, it's going to be nearly 30%. That's driven partly by higher fertility rates, but also by immigration of young people. Then the next two lines that sit right on top of each other are Asia and Latin America. So the moment maybe 10, 12% aged over 60, but by 2050, you in Asia and people in Latin America, the populations will be pretty much as old as in North America and Australia. And the one outlier here is essentially Sub-Saharan Africa, where at the moment only 5 or 6% of people are over 60, and even by 2050, that'll be less than 10%. So the population structure in Sub-Saharan Africa is going to remain young and much younger than the rest of the world. And I'll come back to that in a moment. So if we just look at a few countries in Asia, and I've taken the liberty of including Australia in Asia for this one, 2010 to 2050. So Australia, 2010, about 20% of the population over 60, that goes up to 28% by 2050, just like I showed you in the previous slide. So I won't read all of these out, but you can have a look. China is going to go from 12% to 35%, so very rapid population aging, largely driven by the very low fertility rate, certainly in 2010, a similar proportion of people aged over 60 to other countries in Southeast Asia. But by 2050, it will actually be the oldest country in Southeast Asia, with roughly the same percentage of people over 60 as Australia in 2050. So Vietnam has a very rapidly aging population. And we can actually see that here in this slide. For reasons I'm not completely clear about, a lot of demographers use this 7 to 14%. If you have a look up in the figure title, they look at the number of years that it has taken various populations, or will take populations, to go from 7% of the population being over 65 to 14% of the population being over 65. So doubling the proportion of older people. I actually think they use 7 and 14 because it makes the graphs work. Like 5 to 10 or 10 to 20, but 7 to 14 just works on a graph. And the country that's taken the longest to go from 7% to 14% is France, which took 115 years for its size of its older population to double. And the corollary of that is that France has had 115 years to prepare for an aging population. And in general, the developed countries, the countries that were developed in the 50s and 60s and so on, have aged their populations much more slowly and have had much longer to develop health systems and social security systems to cope with an aging population. If we look at the top, there's Vietnam, 15 years from 7% to 14% of the population being over 65. So they've got a real challenge. And Malaysia, where are you, Malaysia? 20 years, it's not very long, 20 years to go from 7 to 14%. So you really have to plan. I mean, you're lucky France didn't have a model to say, do it like, how should we do it? You can look around the world and look at people that have done this well and people that haven't done it so well. I mean, France, for example, can't actually afford its pension system anymore. So the pension system was too generous for the huge number of older people that are now there. So that's something to think about. I'll give you the reference of this at the end of this talk. It's a nice report from the World Bank on East Asia. Not just about health, because it's the World Bank, so it's more economics, but there is some health in it. All right, just look at another region of the world, Sub-Saharan Africa. And you can see that 2010, most of the countries have 4 or 5% of people aged over 60. South Africa is a little bit different. It's the most developed country in Sub-Saharan Africa. But you look at Ethiopia, it's going to go from 4% only to 7%. But it's still going to be a very young population. Nigeria, 5% to 7%. Uganda, where I've done some work, 3% to 5%. So the populations are going to remain very young. And that's because, as I'll show you now for Ethiopia, the fertility rates are remaining very high in Sub-Saharan Africa. They haven't declined. They've declined, but not as much as in other parts of the world. So this is Ethiopia in 2000. And notice here the x-axis, it goes to a limit of 6 million on each side. This is Ethiopia in 2025, still a population pyramid, but now the axis is 12 million on each side. So they've doubled the number of children aged 0 to 4. And in 2050, it's still a population pyramid, but now you've got 20 million, 40 million boys and girls under 5. So the huge, very high fertility rate is keeping the population young and keeping there being a population pyramid. But 278 million people, Ethiopia is going to, all the big countries in the world, well, they're not going to overtake China and India, but the biggest countries in the world are going to be in Africa, Ethiopia, Congo, Nigeria, massive populations. So I said before that 7% of Ethiopia's population in 2050 would be 60 and over. So 7% doesn't sound much, but 7% of 278 million is 20 million people. So although it won't be an old population, in terms of the percentage over 60, there are going to be a lot of old people in many sub-Saharan African countries, and they're the poorest countries in the world, and they're going to have trouble coping with that. Okay, so I've already hinted at this. Why do populations get older? The main driver is declining birth rates. If you think about it, if somehow today all women in the world became infertile, there were no more babies, or all men in the world became infertile, there are no more babies, in 60 years, 100% of the world's population would be over 60. So it's mainly driven by the fertility rate, but also declining mortality rates, and they're occurring at all ages, as I'll show you in a moment. So infants are surviving, children are surviving, but 60-year-olds are surviving longer than they used to as well. And migration is a way of keeping a population young, because most migrants are young, and in Australia, that's one way that we've kept our population relatively young. So this brings us to demographic transition theory, which I'll just talk about briefly. So for most of the time that human beings have been on the world, a million years or so, human populations have had very high fertility and also very high mortality. So starving to death, dying in pandemics and so on. And population sizes actually up until about 1600 in the world were fairly stable. I mean, they did go up over time. But what happened in the 17 and 18, 1900s was that mortality fell. Fertility remained high, but mortality fell, largely because probably of better nutrition with better agriculture, but also because of health-related interventions like vaccination and so on more recently. And if you've got high fertility and low mortality, you get very rapid population growth. And that's what's still happening in Ethiopia, as I showed you. Fertility is high, but mortality has fallen. The third stage of the demographic transition is where you have low fertility and low mortality. And that's the case in many developed countries now. To the state that some countries' population are actually getting smaller. So this is Australia's population pyramid, just as an illustration from 1982, I think, up to 2050. And you can see that it started as a pyramid going up and up. I can sort of see myself here. I think I'm here. That's me going up here. One of the interesting things about this is that this age group over 100, something funny happens up here. It's because they don't break that down into 5-year age groups. It's just everyone over 100 is lumped together. But, you know, Australia, not a pyramid anymore. It's a different pyramid here, not a pyramid later on. Okay. And that's largely driven by fertility, but also, as I said, older people are living longer. So the life expectancy at age 65, not at birth, at age 65 in Australia in 1960 for a male was 77. So on average, a 65-year-old would live another 12 years. By 2012, that had increased to 84. So in 2011, a 65-year-old could expect to live another 20 years. And similar for women. So life expectancy at 65 has gone up by 6 or 7 years for men and women over the last 20 or 30 years. This is Australia's fertility rates. So back, I guess, post-war, fertility rates were 3.5, 4. They've gone down and they've stayed at around just under 2. Now, of course, you need 2 to maintain the population size. If it goes under 2, you know, if a couple don't reproduce 2 people, then the population's obviously going to get smaller, unless you have immigration, and that's how Australia's kept its population relatively young and not declining in size. A demographer that I work with here in Sydney, Peter McDonald, who I've heard said he's the world's top demographer and talks to our government all the time, mainly about immigration, which he's in support of. He's looked at total fertility rates in different countries in the world, mainly developed countries, so richer countries, and divided them into 2 groups. And he's divided them into group 1 countries where he feels the fertility rate is high enough or has the potential to be increased enough that the populations won't get smaller in size. So even though you know, Australia's fertility rate is 1.8, so it isn't 2, with immigration and with some policy lever changes, that could be increased enough so Australia's population doesn't decline in size. He reckons if you get to a total fertility rate below 1.5, you're in real trouble, that your population is going to eventually disappear. And a number of these are the countries on this side. And when he did this, and I don't think it's changed, the place with the lowest fertility in the world was Shanghai. He just chose a Chinese city. So obviously Shanghai is not going to disappear because people come in from rural areas, but the fertility rate in big Chinese cities among couples is very, very low. And it's interesting, Taiwan, Singapore, Korea, those countries have low fertility rates. He's also tried to link at policies, so countries that have good childcare policies and policies where it's acceptable for women to have maternity leave. Women are more likely to have more children. If it's made easier to have children, it's more likely that women will have children. If you live in a country where if you have a baby, you can't work anymore, then educated women will decide not to have children. And he's differentiated these 2 groups of countries in relation to their, I guess, child-friendly policies. And of course, if you have a very low fertility rate, you'll have an even more rapidly aging population. Okay, so here's just some countries that are going to get smaller. They're going to decline in their population by at least 1 million people. So China is predicted its population is going to get smaller by 60 million by 2050. Now, China's got a lot of people, so 60 million is only a 4% reduction in size. Japan's population is going to fall by 15%, 20 million. And Japan is very worried about this. But we've also got quite a few countries in Eastern Europe, Russia, Ukraine, Poland, Romania, Bulgaria, Serbia, Moldova, Belarus. So Eastern Europe has potentially a big problem, both in terms of population aging, but in terms of actually losing their populations. Interestingly, Thailand is there, your neighbour. In lockstep with the demographic transition and explains the demographic transition. So this was proposed in 1971, and I'm going to come back to this in the last part of my talk and just show you that it probably needs some modification. But Omran talked about an initial stage in the world, going back hundreds of thousands of years, where there were a lot of plagues that might kill 30% of the population. The Black Death in Europe in the Middle Ages killed 30% of people. Huge numbers of people died. And famine, when huge proportions of populations died. So as those disappeared and pandemics disappeared in stage 2, we then have the current stage, which is where chronic or degenerative disease, or NCDs, dominate. I'll say a bit more about that age of receding pandemics, because we're currently in a pandemic, aren't we, at the moment? And I'm just going to quickly show you from data from the Global Burden of Disease. I really like the cover of the 2010 Lancet, so I'm going to use this data. I know it's a tiny bit old, but it still makes the point. We can actually see the epidemiologic transition if we just have a look at the distribution of various diseases, of causes of death in different parts of the world. So in Australasia, all the top 10 causes of death, apart from pneumonia, which is third from the bottom, are degenerative diseases. They're all NCDs or chronic diseases, whatever you want to call them. Infectious disease is not important. And even now with COVID, although that's important, it's not going to be one of the top 10 causes of death in Australia this year. And the pneumonia that we're talking about here is actually pneumonia in elderly people related to flu, and I guess now related to COVID. If we go to South Asia, so this is mainly India, you can see that there are infectious diseases there, pneumonia, diarrhea, TB, but there's also the heart disease, stroke, and so on. So this is very much the double burden of disease that we talk about. If we move to East Africa, and this is still the case, the top 4 causes of death in East Africa are HIV/AIDS, pneumonia in children, malaria, and diarrhea. So all infectious diseases. And TB is still in the top 10. And I'll quickly show you these slides because I love them. This is from the Global Burden of Disease report from the people in Seattle, the Health Metrics Institute. Don't worry about all the colours. Each column represents the number of people that died in that age group. So the first column is the number of deaths in East Africa among little babies aged 0 to 6 days. And over here, it's the number of deaths among people aged over 80. So you can see in East Africa, most of the deaths still occur in children under 5. If we move to South Asia, so India, Pakistan, Bangladesh, and so on, there's a shift to more and more deaths occurring in older people, and those deaths are the degenerative diseases, but still quite a lot of children dying of mainly infectious diseases. Southeast Asia, you guys, still, and this is all of Southeast Asia, so it includes Cambodia, Laos, it's not Malaysia, but there's still a significant number of deaths in children, but most of the deaths are occurring at older and older age groups. And if you come to Australia and New Zealand, very few children die. That's just down here. And all the deaths are due to degenerative diseases at old age. So Omran talked about an age of degenerative diseases. As populations get older, I really think there are 2 stages. There's the first stage, which may be where Malaysia is, where non-communicable diseases are becoming very important. And the classic NCDs, as defined by the World Health Organization, cancer, heart disease and stroke, cardiovascular disease, chronic lung disease, and diabetes. Now, those diseases, we know, particularly cardiovascular disease, we know how to deal with that. And the age-specific rates of death from heart disease and stroke in Australia, for example, have gone down and down and down. I said the age-specific rates because there are a lot of old people, there are still a lot of heart disease and stroke. If we can control smoking, then chronic lung disease will become much less common, and lung cancer will become less common. So we sort of know how to deal with those NCDs. But as populations get older and older, and we have more and more people in their 80s and 90s, I think there's a second stage of the epidemiologic transition where the disorders of real old age become more important. And these are things like arthritis, dementia, falls and osteoporosis, and poor hearing and poor vision. And for most of these things, we still don't know how to prevent them or how to treat them properly. I mean, there are treatments available, but they're not as effective as the treatments we have now for heart disease and stroke and the prevention of heart disease and stroke. So I'm just going to say a little bit about these disorders of old age because you don't normally hear much about them. But I'll point out at this stage that one of the big impacts of arthritis and dementia and falls and not being able to see is that you become disabled. You become unable to participate in normal life. I mean, plenty of people have a heart attack, they survive, they have a stent put in and they get back to doing pretty much what they were doing before. It's very treatable. Arthritis, apart from joint replacement, which not everybody can have and is not perfect. Dementia, we don't have any real good treatments. Falls, we know a bit about, but they still happen. Poor vision, we can treat cataract, but we can't treat macular degeneration. So these conditions of advanced old age are the ones that really cause people disability and lose their independence. So just having a look at these conditions in terms of disability. So this is globally, again, from the Global Burden of Disease Health Metrics people in Seattle. In people over 70 globally, you can see the arthritis conditions up here, back pain, osteoarthritis, other musculoskeletal conditions. You can see hearing and visual impairment here, see falls over here, Alzheimer's over here. Now, COPD, stroke, ischemic heart disease and diabetes remain important, but these other things start to dominate in terms of disability. And the older you get, I'll say this, and there is evidence of it. I mean, when you're 95, you don't expect to live all that much longer. What you want to do is you want to live independently and enjoy life in those last few years that you know that you have. So it's disability that becomes increasingly important rather than life extension. So arthritis, which is something that really, so I have been working in health problems of older people for 30 years and we haven't got very far at all in prevention and treatment of arthritis. I did some work in Uganda back in, I haven't been now for 5 or 6 years, but in the early 2010s, 2008 to 2013, I did quite a lot of work in Uganda, including giving talks in a lot of villages. And this is one of the villages I went to, and I was talking about old age. And it was astonishing how many people arrived with clearly having arthritis and musculoskeletal conditions, you know, wearing, as well as obviously being very poor. But a lot of them came with sticks and crutches. Arthritis is very common in developing countries, probably more common than in richer countries because people do more physical labour. Dementia, I think, is really the big challenge for, hopefully just for the next 20 years until we solve the problem. But it's really the thing that older people fear more than anything else. Someone with dementia, the whole family is impacted. A huge challenge for the world and something that I've become increasingly interested in. So this is data from the World's Alzheimer's report, and it's showing the prevalence of dementia in different regions of the world. And I guess the take-home message from this is it's common everywhere. So the blue line, so they did systematic reviews of all the studies that have been done in Australasia, Asia Pacific, right through to various regions in Africa. They did this again in 2015. And the reason why it looks like dementia has become much more common in West Africa is simply because there are now more studies with better estimates. Looking at these is not to say, gosh, dementia is becoming, exploding in West Africa. It's simply now that we've got more studies. In 2009, they probably only had one study, and now they might have 4 or 5. I guess what strikes me is that in all regions of the world where there've been reasonable studies, 5 or 6% of people over 60 have dementia. And the older age group you look at, the more frequent that'll be. So that in people over 90, it's going to be 20 or 30% of people. Not everybody. The majority of people still don't have dementia, but when 20 or 30% of people are affected by a disease, it's obviously serious. So this is the condition that I started my epidemiological career on. This is a fractured neck of femur. For those of you who are medically trained, you'll recognise this. So my PhD was actually on the epidemiology of hip fracture in Australia. So this is some nice work done in Beijing in China, looking at the change in the incidence of hip fracture. I guess as China has become more westernized, more modern. So they did a survey in Beijing in early 1990s, and those are the dotted lines at the bottom. And they found that, in fact, hip fracture was pretty uncommon and that there wasn't much difference in the incidence between men and women. And they surveyed all the hospitals in Beijing. I think it's high quality work. It was done in collaboration with a group from University of California, San Francisco. And then they went back and did the same thing 10 years later, and they found a dramatic increase in the rate of hip fracture. I mean, let's look at the 80 to 84-year-old. It's gone up, 3 or 4-fold. The age-specific incidence has gone up 3 or 4-fold. And this will relate to some change in the lifestyle of older people in Beijing, and perhaps a change in the exposures that they in their 50s and 60s. So as countries get richer, some diseases get more common. So like hip fracture and diabetes and heart disease and stroke and all those NCDs. So one way of preventing, so this is in Hanoi. There's a lake in Hanoi in the old part there are many lakes in Hanoi, but this is a lake in the middle of the old part of the town, where if you're ever in Hanoi and you get up at 6 o'clock and go to this lake, as I have done many times, you will see a lot of women and men, many of them older. There's this older woman at the back there, and these women aren't particularly young, and there's a man in the background. You'll see people exercising all around the lake. And a lot of the exercise is exercise like this, which is a balance exercise. And if you've got good balance, you're less likely to fall. And if you don't fall, you won't break your hip. So perhaps what's happened in China is that a lot of these exercises that older people used to do routinely, like Tai Chi and so on, maybe they're becoming less common as older people are living in big cities where it's harder to do. Okay, I'm just going to say a few words about the Blue Mountains Eye Study, which was the first big epidemiological study that I was involved in this is about an hour and a half, 2-hour drive west of the University of Sydney. Beautiful spot, really beautiful spot. This was a study that one of its first goals was simply to describe the prevalence of various eye diseases and visual impairment. And what we can see, the upper line is mild visual impairment in both bilaterally, and the bottom two lines are moderate to severe visual impairment, so not being able to see very well at all. And you can see that by the time you're 80 in Australia, where we have really good optometry care, you can get your glasses changed very cheaply, cataract surgery is widely available. We've still got about 5% of people over 80 whose vision is so poor it's hard for them to function. And if we look just having one eye that doesn't work very well, you can see that it's up to 15% of older people who can't see well. So the main causes we found in the Blue Mountains Eye Study of moderate to severe bilateral visual impairment was not cataract, which is treatable, but macular degeneration, which is much harder to treat. And this is the main epidemiological study I've been involved with for the last 15 years or so, a study of the health of men over 70 called the Concord Health and Ageing in Men Project, which involved initially 1,700 men over 70. And I'm using these data just to illustrate the concept of disability. So I'm not looking at diseases anymore. I'm looking at what are called the geriatric syndromes. These are the things that really matter to older people as they get older. Poor mobility was having trouble walking across a small room without help. Recurrent falls is falling twice or more in the previous year. Urinary incontinence is obvious, and dementia. And I guess the two things that stand out for me here are, firstly, among Australian men in their 70s, very few have these problems. So although they might be chronologically old, I think most Australian men in their 70s, they're still fully functional, contributing to the community, looking after their grandchildren, still working, playing golf and so on. It's really only once you get into the mid-80s that these conditions begin to be common. Also looked at frailty, which is defined in various ways, but we've used probably the most widely used definition from Linda Fried in the US. Again, you can see that frailty is uncommon in people, in men in their 70s, and really only becomes common in the late 80s. But by the time men in our study anyway were in their 90s, you've got nearly 50% of people who are frail. That essentially means they're weak, can't walk very far, have trouble carrying things, and this can lead to all sorts of problems like nursing home admission and so on. Okay, I'm just going to finish off. So the epidemiological transition is the shift from mainly infectious to mainly non-infectious, non-communicable diseases, age of pestilence and famine, age of receding pandemics. Then I've talked about the ages of degenerative diseases, NCDs, and the disorders of real old age. But are we now seeing the re-emergence of pandemics? I guess the answer is yes. So when Omran came up with his epidemiologic transition in the 1970s, that was before HIV, or before HIV was a global problem. And HIV is still a huge problem in Sub-Saharan Africa. It's still the #1 cause of death in East Africa. I think some of us think that HIV is a problem that's been solved. Well, it hasn't been. Although SARS and Ebola, I don't think, meet the definition of a pandemic in that they didn't affect lots of countries around the world, they certainly affected countries around the world. When I went to Africa during the Ebola outbreak in West Africa, even though I was in East Africa, when I came back to Australia, it meant I had to be screened more because I'd been to Africa. And then we've got HIV, H1N1 and COVID, which are true pandemics. Just quickly about swine flu, it was actually less likely to affect older people, possibly because they had some immunity from a previous flu outbreak 50 years ago or so. We often think that HIV doesn't affect older people. I think there's this assumption, I don't know, that older people don't have sex or something. Anyway, so my PhD student at the time, Joel Negan, he and I looked at all the data we could get for Sub-Saharan Africa on HIV in older people. And it was difficult to get because most research stopped at 50. And we actually found, and we used 50 at the time as defining older people, and that is the case in the HIV academic world. We found that there were about 3 million people over 50 with HIV in Sub-Saharan Africa. The prevalence in this age group was about 4%, which wasn't much different from the 5% in people 15 to 49, where all the emphasis was. And that of the 21 million people in Sub-Saharan Africa, the adults with HIV, 15% were over 50. So it was a significant problem in people over 50. And I'm very proud of this paper because it really contributed to a change in thinking among people working on HIV, that indeed people in their 50s and 60s do get HIV. Okay, so just to finish up with COVID. So in Australia, we've had, I think as of today, 110 deaths or so. So actually our data up until the last 2 weeks was very similar to Malaysia. Unfortunately, we've had a major outbreak in the state of Victoria, and our picture's changing. But so far, there haven't been many deaths from that new outbreak in Victoria. But up until 2 weeks ago, a picture was very like Malaysia. Our numbers were very similar. Australia's got 25 million people, which is similar to Malaysia, so it really remarkably similar. But I'm showing you this slide to show the age of the people that have died in Australia. This isn't a rate, this is just the number. So you can see that most of the people that have died in Australia have been over 60. And there aren't very many people over 90 in Australia, and yet there've been a number of deaths in that age group. And only 3 people under 60 had died. So just looking at this, I think you can say COVID-19, at least in Australia, but all through the world, is a disease of old people. It might infect younger people, and some of them do get sick, but the people that are most severely affected are older people. So I'm going to claim COVID-19 is a disease of older people. And if we look at case fatality rates, it's probably a little bit out of date now because it's about 3 months ago, but COVID moves very quickly, but I don't think this will have changed. A nice paper only published recently in JAMA, but published as a preprint a little while ago, just looking at case fatality rates. So if you look at in Italy and in China, which were the most affected countries initially. And if you look at the case fatality rate in Italy, so if we start at 30 to 39, you've got 0.3%, then 0.4, 50 to 59, 1%, 60 to 69, 3.5%. It goes up exponentially with age. So it's old people that are most likely to die of this disease. And similar in China, going from 1.3% in 50-year-olds, 3.68, so doubling with every 5 years, with every 10-year age. So COVID-19 and older people. I think this is my second last slide. Older people are much more likely to be severely affected by COVID-19 and are much more likely to die. So that's a fact. But we have to be very careful about ageism here. A lot of talk in the literature about, well, maybe if hospitals are overwhelmed, we won't treat anybody over, I heard it mooted as young as 60. But using age alone as the basis for deciding who we will and who we won't treat if hospitals are overwhelmed. I think that's very dangerous because we know about the heterogeneity of older people. There are some 80-year-olds that are very fit and healthy and some 80-year-olds that aren't. So I think when deciding whether to treat an old people who's sick, very sick with COVID-19, we need to use the same principles that geriatricians use all the time when they're deciding how to treat a very old person. The treatment will be different if someone's living in a nursing home with severe dementia. Sure, you may not try quite as hard. But for an 80-year-old that's still running marathons, you should try just as hard as you should in a 40-year-old. At the other end of the spectrum, there's a lot of talk about, well, we should protect older people. They're at greatest risk. We should force them to stay at home. Lock them into their house so they don't get sick. I think, again, that's very dangerous. We should give older people information that they are at higher risk, but let them choose what they want to do. And for public health workers like us, one of the big challenges is that we have to convince younger people who increasingly know they're not going to die because none of their friends have died. We have to convince young people to social distance, mainly to save the lives of older people. And that's a challenge, certainly a challenge here in Australia. So just to finish, I'm just going to show you 3 reports that are worthwhile looking at if you're interested in this topic. So WHO had a nice report on ageing and health in 2015. This is the World Bank report on ageing in East Asia and the Pacific. And the United States Census Bureau has a nice report on an ageing world. And with that, I'll finish. Terima kasih banyak. Thank you.
Thank you, Bob. That was very interesting and lots of pictures as well.
Probably a bit long. Sorry about that.
No worries, no worries. We've got a few questions. I mean, plenty of questions actually written by the audience. I'll start off with the first question. This is from Corinne Teo, and she's asking, you've done a lot of research, and with the data that you've shown on the different cutoff points for older people, has there been any biochemical markers for aging? And if there is, could you explain a little bit more about the biochemical markers?
So there have been attempts to find a good, we usually say biomedical marker, but a good marker of aging, that something in the blood that tells us how biologically old a person is, and none of them are any better than the chronological age. I mean, the best predictor, although it's imperfect, the best predictor of how long you're going to live is how old you are today. I mean, and then you can take into account the history and so on. But if you just want a single thing, it is your biological age. When I was involved in eye disease research, so cataract, some types of cataract are inevitable, a bit like hearing loss. They're inevitable as you get older. Dementia is not inevitable, but thickening of your lens is inevitable. And I tried to prove, my hypothesis was that the depth of your nuclear cataract would be a better predictor of mortality than your chronological age. So a marker of, but it wasn't. Chronological age was still better. So yeah, no, we don't have such a thing. Okay, next one.
Okay, so next question is, we have a question from Dr. Tarani here. So related to the defined age of older persons, what does those definitions mean in administratively defined retirement age? As the Malaysian retirement age is currently at 60 years.
60, yeah. So I'll just go back from that question a tiny bit, because many countries no longer have a retirement age. So certainly in Australia, there is no retirement age. There are incentives to retire at various ages. So the pension that we have in Australia, the age pension is only available for poorer people. And at the moment, the age pension is available to people who are 65, but we're slowly making that older and older, 65, 66, 67 to 68. So if you're poor, well, relatively poor, we don't have a lot of very poor people in Australia, but if you're relatively poor, you might want to keep working until you can get the age pension at age 65. But no one can force you to work because of your age. In fact, that's illegal. You can take people to court and say they sacked me because I'm old. For other people, there's an incentive to retire at 60, because after 60 you can get your pension savings, the ones that your employer has put aside for you, tax-free. So there are various incentives to retire, but we don't have a retirement age. If you're going to have a retirement age, the problem in Europe is they can't afford a retirement age of 60 anymore. Now, if the government is going to pay all the pensions and you've got 25% of your population over 60, it's just unaffordable. So you need to, for government, pension paid by government, you have to increase the retirement age. And what Norway are doing actually is the retirement age is, I can't remember the exact thing, but rather than putting it in the number of years from birth, they're actually using the number of years before life expectancy. So if life expectancy, for example, in Norway is 84 for women, women can retire at 64. And if life expectancy goes up to 87, they'll change the retirement age to 67. I'm not sure if it's 20 years, but I know it is set in relation to life expectancy. Okay.
Thanks, Bob. The next question, we've got audience ranging from Malaysia, Brunei, and Singapore, as well as Thailand. So this is a question from Singapore. Okay. You've put up a lot of data, interesting data, comparing countries with regards to the demographic situation. So what are the challenges getting cross-national related big data sets on population aging for comparable purposes, especially to look at the historical trends, and how do we address these challenges?
So demographic data is actually surprisingly easy to get. And a lot of what I've shown that demographic is the demographic comparisons. They come from the US Census Bureau. Now, it's, many of us, including me, are often critical of the United States and some people in the United States. But I guess because America has been the dominant global power for the last 100 years, they also have collected a lot of data about many countries around the world, and so in demography they're the leaders, and so you can go to their database online, the US Census Bureau database, go to the international section, and you can pick any country in the world, and you can look at the age structure of their population since 1950 with predictions up to 2050. And you can also look at fertility rates, mortality rates, a whole bunch of data. Basic demographic data is very easy to get.
Thank you, Bob.
Comparisons of health-related data are harder. I mean, there's a global burden of disease, people, obviously, but when you're trying to compare, rates of disability, there is no single data source. You need to search the literature and find what you can.
All right, thank you, Prof. Khan. So we have another question here from Susan. So since Malaysia only have about 20 years to reach population aging, how can we prepare our health system to cope with this demographic change?
Well, I could say that's your challenge. I guess, so in the health system, I'm sure that now you're very capable of treating people with the sort of diseases that older people get. I'm sure you have very high quality cardiac care and so on. So I think in the acute setting, you're probably well prepared. I think a bigger problem will be possibly things like the health information systems, whether they're capturing all that information. And I suspect in Malaysia they are, I don't know. But I know that in poorer countries, like in Myanmar, the health information systems are still very focused on infectious diseases and diseases of mothers and children, which may be appropriate in Myanmar, although they also have an ageing population. So there are things like the health information system, availability of treatments for hypertension and diabetes. I guess availability of things like joint replacement therapy, which particularly hip joint replacement therapy is very effective and needs pretty good. So they should be widely available. So that's on the medical side. So an increasing focus on the NCDs. I guess you also need to have support services for the very old with mobility problems and cognitive problems. Now, that support for such people are traditionally provided within families. And I know in Myanmar, where I was last year, it's still predominant. Well, the claim is that it's still predominantly provided. We don't have a lot of data, but it's still provided by families. So older people, grandparents live or great-grandparents live with their children and their grandchildren and their great-grandchildren. But as countries modernise and people become better educated and both partners in a relationship work, that becomes much more difficult. And I'm not sure where Malaysia is at the moment in that, but in the future, it will be harder to provide care at home for very disabled older people. And so you've got to work out a model for that. Now, we have a lot of nursing homes. I hate nursing homes. For 30 years, I've been saying nursing homes, who would want to live in a nursing home in Australia? And if you ask older people, they dread it more than getting dementia. Now, they would rather be dead, many of them, than live in a nursing home. So if you're going to have institutional care for older people, you have to make it a nice place where people want to live, be able to bring in their own furniture, make it easy for their family to visit, make it feel like a home, not like a hospital. Or ideally, though, you would provide home services for people. If the family can't provide the service, then there should be home care workers that can provide a lot of that care. It probably is a little bit more expensive than a bad nursing home, but it's so much more humane. And I guess the final thing is, I don't know much about your pension system, but as more from the financial side of things, as the population gets older and there are fewer people working and paying taxes, then the country has to work out how to support that.
I think my obvious reaction to that is that we really need another seminar or webinar to look into the issue more in detail, because there's a lot of questions asking about how do countries actually prepare for aging population.
Yeah.
There's another one. I think we've got a lot of information given by Datin Jacqueline Wong. She has put up a lot of data and information. She's from Brunei. Thank you, Datin. Yeah, she's also a part of our audience here. And look at the group chat for those who want information. She has put up a lot of information, especially on dementia. And there is a question on dementia.
Yep.
So with regards to the NCD, especially mental health issue and dementia is going to be an issue on aging population. So how do a country prepare, or what constitute a good mental health surveillance, especially for the older adults, especially in related to indicators? What kind of indicators can a country pick up or follow through so that one is prepared to look into this issue?
It's really hard. I don't think any country does that well. I guess at a minimum, when people are admitted to hospital with whatever they're admitted with a broken hip, they're admitted with pneumonia, but try and record their cognitive capacity. In Australia now, we're now introducing a mandatory policy for hospitals to be accredited that everyone, I think it might be over 60, as well as having their temperature taken and their blood pressure taken, needs to have some sort of simple cognitive assessment done, like a mini mental state exam. It's not mandated which test you use, but that everyone should have their cognitive, over 60, should have their cognitive status assessed on admission to hospital. Now, the reasons for that aren't so much for keeping an eye on the overall statistics on cognitive impairment. It's more that if you're admitted to hospital with a broken hip and you already have dementia, your care is going to be much more complicated. You might tell the older person, well, don't get out of bed. They will get out of bed if they have dementia. Also, they're much more likely to get delirium when they're in hospital, which is a huge problem in hospital. So monitoring cognitive impairment among people in hospital is something that's increasingly being done. But to actually get data on the number of people that have dementia in a population is really difficult. And we haven't actually done it well in Australia. We extrapolate from studies done in Europe and North America. So it is hard because to diagnose dementia, there is no blood test like for diabetes. You really need to spend probably an hour with someone and also interview their family to make the diagnosis, at least an hour. So it's really hard. But I'd be very interested to hear more about Brunei because it's a country that, well, I've been to Malaysia probably 6 or 7 times in my life. Brunei is not somewhere I know much about at all. So maybe I should come there one day.
Yeah, we can link you with Datin Jacqueline. She's here on one of the audience listening to you. Back to you, Nick.
Okay, all right, Prof. There's a question on community engagement programs for elderly people. So this one participant, Dr. Razita from Unimas from Sarawak, she wants to know if there's any community-based project in Australia focusing on elderly people that you can share with us.
Does that question mean, are there activities that older people can do in order to get them out of the home and keep their body and mind working? That's sort of like group activities.
Yes.
Yeah. There are various ones that exist, but I suspect Malaysia might do that already better than Australia. I know with Noran, we went and visited years ago. We visited a group of older people that were working together in a community hall, and it looked wonderful. So in Australia, I guess we have. We do have groups, although they tend to be better educated groups where people get together and either one of the group will make a presentation, maybe 20 or 30 people come together for a talk. I've given talks to such groups. A lot of older Australians, certainly those in their 60s and 70s, play golf. So and lawn bowls. So a very sort of English Australian thing. So a lot of people go to the bowling club and the golf club, and even if they don't play, that is a place where large numbers of older people will get together. So these are older people that can still get out of the home on their own. For very elderly people, with disabilities, because there are still very elderly people playing golf and bowls, but there are senior centres which have 2 purposes. One is the older person has somewhere to go where they can talk to other older people with disability. They also get a meal, they get out of the house, and they give some respite to their carer when they're at home. So if there's, as is often the case, either a daughter or, as people get older, I think we often forget that the main carer is their spouse. So if you're a very old woman with a husband who's not disabled, your main carer will be your husband. The problems occur when you don't have a husband anymore. One of the nice things about being a man is because we die younger than our wives, which is not good, but because we die younger than our wives, we, as we get old, tend to have a wife to look after us. So men don't need as much in Australia. Men are much less likely to be admitted to a nursing home because our wives look after us, and then we die. And then as the wife gets older, she doesn't have anyone to care for her. So these senior centres give the opportunity for the person in the couple with a disability to go and spend 1 or 2 days a week and the other older person can have a bit of a rest from the level of care they've been providing. So things exist, but I suspect that they're better in many other countries, including Malaysia already.
Thank you, Prof.
This is the COVID year, so there are plenty of questions on COVID.
Now, I'm not a expert at all. It's funny, being an epidemiologist during COVID, everyone, well, two things. One, now everyone knows what an epidemiologist does, or they think they know. Whereas in the past, if you tell someone you're an epidemiologist at a party or somewhere, they have no idea what you do. So they sort of know what we do now, but they all think I'm an expert on COVID, and I'm not. So I'll be careful how I answer these questions.
So it's basically back to issues on COVID and dementia and ageism.
Yep.
So there have been reports that COVID presents with some form of cognitive issues among the older people. So how then do we differentiate whether one has cognitive impairment, or is it COVID related? And will it be, I mean, in years to come, how will this going to be? And it's also challenging with the COVID-19 pandemic, especially especially those in nursing home or institutional settings. They are much more at risk. So how do we draw the line between protecting the elderly as well as ageism against the issue that we're facing right now?
So there's no right answer to that, to that last question. And I don't really know much about the cognitive effects of COVID-19 other than, anything that gives an older person a temperature and makes them unwell is going to, I was going to say exaggerate, but make worse any cognitive defect that they already have. And related to that, one of the issues with older people in nursing homes with COVID is there's been a lot of debate in Australia, well, should we move them out of the nursing home into a hospital just automatically? We're not doing that. Some people think we should, some people think we shouldn't. I probably lie on the side of not doing that. Most people in nursing homes in Australia, more than 50%, do have some cognitive impairment. Moving older people into an environment that they're not used to, like a hospital, is going to make that cognitive impairment worse. So I think it's worse for the older person. So I think what you need is to have really high quality infection control PPE in the nursing home. And we've had some breakdown of that in Australia. We had one big nursing home. I mean, up to now, forgetting what's happening in Victoria at the moment, up to now, we've only had a small number of big nursing home outbreaks. And that was clearly through staff not being well trained. If staff are well trained, it shouldn't happen. We have one of the bigger problems in nursing homes is whether the older people should be allowed to have visitors if there's some COVID in the nursing home. And that's also been a debate. I mean, in that big nursing home outbreak, we said no visitors. As the situation like in Malaysia and in most of Australia now, it's settled down, visitors are allowed, but with much better infection control than there was before. It is a challenge, isn't it? I mean, if we really want to control it, then I guess as soon as it's diagnosed, the people would be taken and put in hospital. Now, in Malaysia, I think people with COVID-19, once they're diagnosed, are asked or mandatory have to go somewhere else. We're not doing that in Australia. If you're positive and you're well, you self-isolate at home. So you're only admitted to hospital if you're sick. So it might be different in Malaysia, but in general, the people stay in the nursing home, and I'm happy with that approach.
Yeah, in Malaysia, for those who have been diagnosed with COVID-19, they are all put in the hospital or in the quarantine centers. Yeah. Except for now, those who are returned back from overseas who are Malaysians who have COVID-19, they are asked to be quarantined at home. But I think that's going to change soon. Listening to our Director General's press conference, I think a few days back. So back to you, Nick.
Okay, moving on to the next question. So this question is about funding. It's from Khairul Ashraf here. So he's asking about, he's saying that funding towards healthcare depends on the worker population as worker population decreases due to aging population, how are we able to maintain the pooling of such fund in order to support the whole population?
Well, the simplest answer is to increase taxes on workers. But workers aren't very happy with that. So it depends on your system of financial support for older people. So if, like in Europe, in many European countries, it's entirely based on tax income, that's just unsustainable. It's not going to work. Young people aren't going to want to pay more tax. And there are all sorts of reasons why we don't want people to pay more tax. I'm not an economist, but high taxes are often a disincentive to work harder and so on. So one option is to increase the retirement age, so you keep paying tax until you're 70, but that's also not what most people want to do. So instead of having a pension system based on taxes paid by current workers to support non-workers, the idea in Australia is to encourage people to save for their own entire retirement. And that saving can be in two ways. One, put aside your own money in a way that, and there are tax incentives to do that. The money that you save, you pay less tax on than if you spend it. But also we have what we call superannuation, where your employer puts aside a significant amount of money that you can only access when you get to 60. So we call it superannuation. It has other names, I'm not sure. And many employers do this. But in Australia, it's mandated. Every employer has to, so if someone's being paid $100,000 a year, for example, the employer has to put $9,000, 9%, into a superannuation fund on behalf of that employee. And that money accumulates over time. It's invested usually well by the superannuation company. And then when you retire, you access that money. So it's a mandatory system of employers having to put aside at the moment 9% on top of the person's income into a savings fund. And that in Australia, that's working well. And I work with some economists who are much better, know much more about this than me. And they think Australia's system is among the best in the world, if not the best. Because pension is means tested, so it's only provided to poorer people who don't have enough to provide their own for themselves. So I'll recommend a superannuation system for everybody, not just for, even if you run a small business and you employ one person, you pay them whatever you pay them, plus you have to put 9% into a fund on their behalf.
Thank you, Bob. There's a question on the services for the older people. You mentioned about nursing homes or institutionalized care for the older people in Australia. What other services are there? Can you explain a little bit more about the services available in Australia?
So beyond, so in terms of health services, I mean, really nursing homes aren't really a health service. I mean, there's a bit of a debate now in Australia whether nursing homes should be there only for older people who are nearing the end of their life and who do need high quality clinical care. And that anybody who doesn't need high quality clinical care really should be cared for in the community. And that would be the ideal. I mean, there comes a time when for some old people, when they really can't be cared for at home anymore, with severe dementia, immobility, it's just not possible anymore. So then they do need to go somewhere, some sort of institution, which will be more like a hospital, and that's okay. We have a problem in Australia that the clinical care in nursing homes often isn't of a very high standard. So that needs to be improved. For other older people, main care is provided by general practitioners. So general practitioners care for older people, they refer them in the normal way. One of my concerns is that they often don't manage them taking into account, I guess, the complexity of the medical problems of an older person. So there will be an older person who has, I don't know, let's say, cardiac problems. So they get referred to a cardiologist. They have some gastroenterological problems. They might have a bit of a hiatus hernia. So they get referred to a gastroenterologist. their renal function isn't so good anymore. They get referred to a renal physician. So that many older people have 5 or 6 different subspecialty physicians. They might have a dermatologist as well for the skin cancer that all Australians get. So they have these multiple different specialist physicians. And that's, well, whether that's good medicine or not, I don't think it is, because they don't always all agree. And the cardiologist puts them on more drugs for their heart, and someone else puts them on more drugs for this or that. But it also means, and actually I'm in this situation myself with my father, who's 91. I think he has 7 specialists the last time I counted. Now, until recently, he drove himself to those specialists. He's not able to drive anymore. So I have to take a day off work to take him to the specialist. And my mother has to stay at home on her own all day, which she can, but in future, maybe she can't. So I think we need to be careful. As people get older, they have multiple conditions, and we need a different approach for them than 10 different specialists. Now, obviously, the alternative is a geriatrician who is a general or a general physician. You know, a good old-fashioned general physician. We don't have many of them in Australia anymore. The only general physicians we have are really geriatricians. And really, someone like my father should be seeing a geriatrician. But there are 2 issues. One, there aren't very many geriatricians outside hospital. So when you're admitted to hospital, you might have a geriatrician, but in the community, there aren't many. And also, older people like my father don't want to see a geriatrician because they don't feel that old. They don't want to see this doctor that's only for old, frail people. They want to see normal doctors. So it is a challenge, but I think maybe we need more general physicians and not label them as geriatricians to provide that specialist care that many people need. But general practitioner is incredibly important. Okay. How are we doing?
Good.
I'm glad there have been so many questions, and I'm glad so many people have participated. I suspect if I were giving this talk in Australia, there would be less people interested and there would be less questions.
There's still more questions that we're going to ask you about.
Well, maybe part of the reason in Australia is that, no, I don't know. I was going to say that because we've had so many old people for so long, everybody's sort of used to it. It's not exciting, but that's not true. Most people don't know the stuff I've just told you. We still don't have a lot of geriatrics in our medical student curricula. We have a lot more than we did 30 years ago, but still not a lot.
All right. Okay, so moving on to the next question. So okay. This is following to Dr. Hiziani's question on services. So this question is from Cairo. So he saw that a lot of universities in Australia offer courses like social worker, and some have aged care social worker up to master level. So is this part of the plan of managing aging population?
It's not a plan. It's certainly not a plan of anybody. I would say universities have just seen a business opportunity that there is a demand for that sort of training, and so they provide it. I mean, social work is a well-established career in Australia. We've had bachelors of social workers, well, at least for 40 years that I know of. My wife's actually a social worker. So bachelors of social work is a well-established career path in Australia. And increasingly, social workers work with older people. So there is a demand for that. So is there social work are there bachelors of social work in Malaysia? No, I can see some shaking heads. Okay, so the social workers in Australia they tend to go in 3 different directions. And in fact, the degree at the University of New South Wales that I know most about has 3 different subspecialties. One is community work, which is what my wife did, which is more working with a whole community to improve access to services, to improve the quality of life of a group of people. And those people will often end up working in social policy in a ministry. Then there's people that do group work, more like a psychiatrist might do. So working with a family, with small groups of 4 or 5 family members to solve particular social issues. And then there's individual social work, which ranges from more like a psychologist, but through to helping people access services, or if there's a difficulty in a family where the parents have problems, alcohol, drug problems, should the child remain in the home or not, a social worker will be involved in that decision making. And certainly in aged care, social workers are involved in the decision making about whether an older person needs care in an institution.
Thanks, Bob.
So you need more social workers, without a doubt, by the sounds.
Yeah. Yes, we do really need them. This is a question on caregivers. You mentioned just now about caregivers. The trends or profiles of caregivers are mainly spousal caregivers.
Yes.
And in your studies, in the CHAMP study on men, what roles do men play in providing caregivers to their wives or spousal caregivers?
Well, it's a good question, Naran, because up until the last, so we're up to wave 5 of the CHAMP study. So we've got about 5. So we started with 1,700 men. For those of you who are epidemiologists, there are good and bad things about studying very old people. One is you get a lot of outcome events quite quickly. So, you will get a lot of stroke, you'll get a lot of deaths, you'll get a lot of fractures. The disadvantage is you'll have a lot of loss to follow up because of death. So, then if you go back 5 years later to a group of 70-year-olds, 20% won't be able to participate in your follow-up survey because they'll no longer be around. So in CHAMP, after 15 years, we're down to 500 men out of the original 1,700. And in this wave of CHAMP that we're just starting to analyse now, we're looking in a lot of detail about the care provided by men to their wives and by wives to the men. Up to now, all we've really known is whether or not they're providing care. So we do know that both from CHAMP and other studies that, yes, the predominant carer for old people is their spouse, and the second most likely carer is a daughter, which will be the same around the world, I'm sure. Yeah, but we're looking in more detail at that now. One of the things that I regret not looking at earlier was providing support to grandchildren, which is quite common. Unfortunately, our CHAMP men are now in their, they're all over 82. And most of them have stopped looking after grandchildren. They now have great-grandchildren. So I don't really know the answer to that question other than anecdotally. And
Thanks, Bob.
All right. So I think other questions have kind of been covered in your lecture.
That's great. Yep.
Yeah. Is there anything else from your side, Prof. Noran?
Oh, yes, I do. I do have some questions for Bob. Back to more questions. I hope you don't mind. This is regarding the issue about dementia. You mentioned about dementia. Dementia is going to be one of the biggest public health problem. And one of the things that we don't have right now in Malaysia is how do we influence our government to come up with programs or preventive programs in dementia? And with regards to dementia, is early life approach the most important target?
So for preventing dementia, the evidence is strong that probably the single most important thing is to control blood pressure in 40 and 50-year-olds. So that's probably the single most important thing. Probably obesity in that midlife period is also a strong risk factor. So I guess the sort of things that control heart disease and stroke are similar to the sort of things that will control dementia. I mean, the risk factors are very similar. So they're the key things. So good quality cardiovascular disease risk factor management in 40 and 50-year-olds. By the time you're 80, it's probably too late in terms of dementia. So that's the prevention. In terms of raising awareness or getting governments to do things, I think what happened in Australia is a couple of things. One is as the population as the proportion of people in the 80s and 90s goes up, it becomes obvious to everybody that it's a problem because people have, people's parents have dementia. So the Minister for Health's parents will have dementia. I'm not sure how old your Minister of Health is, but it just becomes more clearly a problem. The other thing is advocates. So in Australia, we've had some really strong medical advocates for dementia that are always going to government and saying, you've got to do more, you've got to do more. So these are professors of psychiatry and professors of geriatric medicine who've really advocated for their disease, and they've been successful. There's now a lot of money for dementia research. 30 years ago when I started, very hard to get money for dementia. Now it's possibly the easiest thing to get research money for, actually. We have a national dementia policy. Each state has dementia policies. 2 or 3 years ago, I chaired a group that we put together guidelines for dementia prevention and management. So it's really got on the agenda, and I think it's the advocacy of a few key people, and just the fact that it's so clearly a problem now in Australia. Everyone's family has someone with dementia.
I think coming back to that, the National Health Mobility Survey of Malaysia just released their data recently. This is for last year, and quite alarmingly, our prevalence of non-communicable disease, especially hypertension, diabetes, obesity, are all rising. And I can foresee that this is going to be a group that will be affected much later on, and intervention or prevention has to be started earlier, even at the age of 40 or mid adults, rather than waiting until they have reached the age of 60 years old, then only intervene. So I just want to get the message across that I guess we need to push for a dementia plan or prevention of dementia plan early, looking at what other countries have done.
Yes. So I don't know if you know, Naran, but my wife does much more dementia work than I do. And she's actually been one of those advocates, I think, at government, within government for dementia, not from outside government, but within government. And she's been involved in dementia plans in Australia. And I won't volunteer her to provide some advice, but I'm sure she'd be happy to.
Oh, we'll get her for the next webinar. I think that will be very good.
The other thing, I guess one of the big things that prevents dementia is high levels of education in adolescents and children. So the better educated you are, the more you use your brain as you go through life, and the more you use your brain, the less likely you are to get dementia. It's not as simple as I think some Australians think of doing Sudoku when they're 80. Apparently doing a lot of Sudoku makes you very good at doing Sudoku. but doesn't prevent dementia. But being active and better educated people are less likely to get dementia. So all of us are at lower risk than people with only a primary school education. Doesn't mean we won't get it, but we're at lower risk. So as populations get better educated over generations, we'll see a decline in age-specific incidence of dementia. But because we've got more older people, we'll see an increase in the absolute number. So there have been studies now, I think definitely in the UK and Scandinavia, and I think the US, where they've actually compared the prevalence and incidence of dementia now compared to 20 or 30 years ago, and they've found a lower rate, age standardized rate. Once you adjust for the different age structure of the population, there seems to be a decline. And that may well be due to better education of the cohort effect of better education across the 20th century.
Bob, the thing about dementia is that those living with dementia actually experience more stigma than those with physical health. So how does Australia, work against this? What are the actions or activities that has been done in Australia that you can share with us?
I'm trying to think. There definitely is a stigma attached to it, although perhaps not as strong as it was, because more and more people have a family member with dementia. There have been some advertising campaigns, not so much about dementia, but more about healthy aging. Because I think it's a bigger problem just of ageism that people, I've noticed, and I'm not quite, I'm old by one definition, but not by the other definitions. I fall in between the OECD and the UN definitions. I've noticed sometimes that I'm starting to be a little bit invisible. I'll walk around and people don't notice me anymore. It's quite strange. So I think there is this attitude and as we get older, you know, by the time I'm 80, God knows what it'll be like. But where the respect for older people is not as high as it was. And also there's a feeling that, you know, that all older people have dementia, for example, which even among 90-year-olds is not true. Or that, you know, all older people can't do things. Older people can't use the internet, for example. Well, most people in their 80s in Australia do. You know, they mostly have computers, most have smartphones. There's just this feeling that we do lose our physical and cognitive ability as we get older, and it's true. We're not as sharp as we were, but so we just need to give examples of healthy older people. Being careful not to emphasise the marathon runners or the people that jump out of aeroplanes with parachutes, you know, that you see on television every now and then, but just more generally that most older people are still able to contribute to society.
Then there's the other thing about dementia as well. Planning ahead is important, especially when it comes to handling legal affairs when cognitive is being impaired. So what happens in Australia? Do you have things like adult guardianship or anything like that?
Yeah, so there's a whole range. And, you know, Naran, you really should be talking to my wife now. Who knows much. So advanced care planning, power of attorney, all those things are being encouraged more and more. So the health department in New South Wales has a website where you can go and find examples of documents, the sort of thing you should be thinking about, and there's a big push in that in Australia at the moment, and I think people are becoming more aware of it.
There is a question from the audience. Would you know, with regards to research, is there any music therapy for people with dementia in Australia?
There definitely is music therapy, and there's definitely research on music therapy. But I'm not going to, because we included it in our guidelines, but I can't remember what the answer was, how effective it was. And also, I guess, how do you measure the effectiveness of something like music therapy? You know, is it effective in slowing the rate of cognitive decline? I don't know. There have been actual randomized trials that you could find. On the other hand, if it means that older people are, you know, come alive, that they're smiling and happy and singing along, you know, that in itself is probably a good outcome. And I'm not sure what the evaluations have looked at, whether it, you know, stops the decline in cognitive performance or not. Something like that might be worthwhile.
Thank you, Bob. I think maybe just this is the last final question. Okay. From me. We know that you've been talking for almost 2 hours already.
Right. I like talking. It's okay.
What are some of your advice for those researchers? I know from the list we've got almost 100 people listening to your talk this morning. Without the Facebook and the YouTube, I'm sure there are more there. But for us researchers, you've done a lot of research. So what advice can you give us, especially with regards to doing longitudinal or cohort research from your side?
I mean, it's difficult to get funding for cohort studies, longitudinal studies. It's difficult to get funding to do research, you know, full stop, but it's particularly difficult to get funding for cohort studies because, so the longest grant I've ever got is a 5-year grant. So that was for the Concord, the CHAMP study. So we got 5 years funding, which meant I could do the baseline survey and see people 2 years later. So that's all we could, it takes about a year to set things up, a year to see people, and then the 2-year follow-up. Subsequent follow-ups, so we're up to our 5th, were each funded separately. So I had to apply to do a 5-year follow-up. Initially, when I applied for a 5-year follow-up, I didn't get the funding. And the feedback was, this is boring, you've already done all of that. Because I just wanted to ask the same questions, but in over 5 years to see how things had changed. So I applied again, and it turned out to be 6 years funding, and we added a nutrition component. So it looked like a new project. So we did nutrition plus everything we'd done at baseline. The 8-year follow-up, we added oral health. So I think depending on how your funding goes, you probably just need to make each wave look different from have some aspects that are different from the previous waves, so that they'll fund the new stuff, and at the same time you can do the old stuff. The wave we're doing now has a focus on social determinants of healthy aging. and that includes the caring. But we're also still looking at blood pressure and all the things we used to look at. I think it is challenging to do longitudinal studies. I'm involved with a group that has been directly lobbying the government to fund a longitudinal study of ageing of a representative sample of older Australians, similar to what's been done in most European countries and North America. Because for that, we'll need millions of dollars, and we're not going to get that through the normal research funding agencies. So we've been sort of badgering our friends in government, but we haven't been able to get that. I think to do a good longitudinal study, you need to know that your funding is going to last at least 10 years, and you probably need direct funding from government rather than through the usual research funding agencies.
Thanks, Bob. Anything, Nick?
Okay, I think we have no more questions. Thank you very much, Prof. Robert Cumming, for the great lecture, and also Prof. Noran for moderating today's webinar. Okay. And to all the participants, we appreciate your attendance to our webinar. So we wish you a very good day and stay safe, everyone.
Yeah. And thank you, everybody. I've really enjoyed it. I wish I could be in a lecture theatre with you, but I can't. And hopefully I'll come to Malaysia soon and enjoy the hospitality of your wonderful country. Thank you. Bye-bye.
Thank you.
Thank you, Bob. Thank you.
Prof.
Thank you, everyone.
Bye-bye.
Bye. Thank you, Prof.
Thank you, Prof.